So I'm Dr. Todd Levine. I'm a neurologist in Phoenix, Arizona, and I run a neuromuscular center. We specialize in patients with nerve and muscle diseases there. As a result of that, I see a lot of patients with all forms of myositis, so polymyositis, dermatomyositis, and inclusion body myositis. But I also see a lot of patients with other neuromuscular diseases, particularly Lou Gehrig's disease. And in Lou Gehrig's disease, the vast majority of patients end up with dysphagia and end up requiring a feeding tube to prolong their life. So it's a very important part of our treatment plan for those patients. My particular interest in dysphagia goes back about 9 or 10 years ago when sort of two things happened simultaneously. The first was a really wonderful patient of mine that had ALS progressed to the point of needing a feeding tube. And she and her partner wrote a cookbook called the Dysphagia Cookbook. And they asked me to write the introduction to that cookbook. And one of the reasons for that request was at the same time I had my own illness and required actually a feeding tube to be placed for myself. So I had about a 9-month period where I had a feeding tube. For about 3 of those months I was at home sick. But for about 6 of those months I worked, and it really kind of stuck with me that people have this sort of terrible image of feeding tubes and think about feeding tubes as being sort of something that happens only at the end of your life. But for me it was something that I was able to work with, I exercised with. My kids were young at the time, and so they would fight over who could pour the tube feeds down and feed daddy that way. And it really was something that was not very difficult to either manage or to live with. And so I think that many patients are reluctant to even have their dysphagia evaluated because they know that one potential outcome for that could be a feeding tube. And the concept of a feeding tube is so scary to people. And so I really like the ability to interact with people that are having trouble with swallowing and to get them to understand that there's really 2 reasons that we eat. That we eat because it tastes good, and that's fun, and that's a good thing. But we also eat because we need nutrition. And particularly in myositis, where we're trying to do everything we can to keep the muscles healthy, the one thing that we know is vitally important is being able to maintain a patient's nutrition. And so if a patient is starting to lose weight, I start to talk to them very early about the need for a feeding tube. And then the other thing really to kind of keep in mind is that even if a patient does end up with a feeding tube, it doesn't mean that they can't eat. And that's another misconception. So that most of my patients that have feeding tubes still eat some amount of food because, again, it tastes good, it's fun, and they can go to restaurants and be with their families. But then they have the feeding tube there to be able to make sure they have enough nutrition to keep their muscles healthy. So with myositis, most patients really present with muscle weakness as their initial problem. So they'll come in with weakness in their arms or their legs. But it's not uncommon to have somebody come in and their initial symptom really being swallowing problems or choking or weight loss. And then as a neurologist, we have to evaluate them and try to figure out what's causing that. And then that can lead us to the diagnosis of the myositis. It's also really important as we treat patients with myositis that we ask for all the potential other issues that can occur outside of the muscle. So there's a lot of attention obviously that's put on the lungs. Patients with Joe-1 syndrome can develop interstitial lung disease. Obviously we pay attention to the rash in patients with dermatomyositis, but it's equally, if not more important, to really pay attention to a patient's swallowing. And so that's an important question that needs to be addressed with your physician at least a couple of times a year to really say, are you choking? Are you having trouble swallowing? Are you losing weight? Are meals taking longer? And if the answer to any of those symptoms are yes, then it really should be evaluated. And one of the things that's difficult about dysphagia is there's so many different potential causes for dysphagia. So even in patients with myositis, we frequently find that they have another cause for their swallowing problems. That cause could be something simple like a hiatal hernia or an esophageal stricture, and those things are very treatable. So again, I think that sometimes when we bring up, we want to get a modified barium swallow and we want you to see a speech therapist, patients are often reluctant to do that because they're kind of concerned again about going down that pathway toward a feeding tube. But there are many exercises that can be helpful. There's many swallowing techniques that can be used that can be helpful to improve a patient's swallowing. So it's very important to work with a speech therapist that can then evaluate your swallowing and figure out whether it's progressing with treatment or needs other type of modalities. So probably the biggest risks that we worry about with dysphagia is the malnutrition, and then we worry about aspiration. So if the food is not being moved correctly in the mouth and in the back of the throat and then down the esophagus, the food will end up in the trachea, which leads to the lungs. And so patients can end up with recurrent infections. They can end up with aspiration pneumonia, which can be life-threatening in some cases. And then in severe cases, if the food actually gets lodged there, actually choking on the food can be life-threatening and lead to a 911 call that we'd rather avoid. All forms of myositis definitely can have dysphagia. It's true in poly and dermatomyositis. Where we see it most commonly is in inclusion body myositis. And one of the reasons for that is that inclusion body myositis seems to involve the muscles of the esophagus a little bit more than it does in poly and dermatomyositis. So I think also because obviously inclusion body myositis doesn't have any kind of specific therapies right now, as the patients develop the dysphagia in IBM, we are worried that a year to 5 years later that's going to get worse, and so it's something that we follow very closely. In poly and dermatomyositis, the hope is that if we recognize the dysphagia, that we would just increase how aggressive we are in treating their muscle disease and hopefully make the dysphagia better. Having said that, there's sometimes a separation. So sometimes you can make somebody's arms and legs stronger, let's say in polymyositis, but their dysphagia does not get any better, or vice versa. The important, again, point to understand about dysphagia is that it's probably the most complicated neurologic mechanism that we have. So in terms of the way you have to chew and swallow, move the food in the mouth, sense the movement of the food in the mouth, know when to swallow. It's a very, very complex neurologic function. And so as a result of that, the patient's symptom, which could be choking or weight loss, will all sound the same, but the cause for that is multiple. And again, everything from muscle weakness from the myositis to problems with the tongue or teeth, or problems with structures or strictures in the esophagus, or even cancers that sometimes can be identified. So there's so many potential causes for the dysphagia that it's very important that we figure out how to evaluate it and evaluate it aggressively. Again, I think typically that would start with speaking with your doctor, whether it's your primary care doctor or the neurologist or rheumatologist that's taking care of you, and then hopefully having them get you to a speech therapist that can evaluate it and identify where the problem is. And then once we've identified where the problem is, then we can start to figure out whether there's ways to treat it or not. Having a feeding tube does not mean that you can't eat food. So there's a number of issues to keep in mind there. Again, we use the feeding tube to make sure that a person's having enough nutrition to maintain their weight and to keep their muscles healthy. Once the person gets the feeding tube, if their swallowing problems are bad enough to need a feeding tube, the next step then is to work with the speech therapist and to say, okay, well, what kinds of things can I swallow safely? Or maybe if I tuck my chin and I can swallow this safely. So then we can go back and say, okay, these are the type of consistencies of foods or the types of foods that this person can eat safely, and then that person can eat. The other thing is that it's very easy to take feeding tubes out. So it's a very simple thing to take them out. So particularly in poly and dermatomyositis, just because a person needs a feeding tube, the hope would be that in 6 months or a year, once their disease is under better control, that now their swallowing's better, and we just take the feeding tube out. It leaves a small little scar on the stomach, but really nothing major at all. So the main treatments for the dysphagia would be either treating the underlying muscle disease. So if they had PM or DM, we would put them on steroids or whatever medication they would get to treat their disease, and the hope would be the swallowing would get better that way. If patients have IBM, we obviously don't have much in the way of specific treatment for that. And then the treatments for the dysphagia really come down to figuring out how to help the mechanics of swallowing get better. So by working with that speech therapist, they can say, oh, if you tuck your chin, you're able to swallow better, or making sure you eat upright as opposed to being more laying down, and that can make the swallowing better. So there's a lot of mechanical things that we do. We'll change the consistency of a person's food, and that can be helpful. Sometimes patients will find they need to take a bite of food and then alternate that with a sip of a liquid, and the liquid will help the food go down, and then they can go back to the solid food and back to the liquid. So there's a lot of mechanical procedural things we do, but we don't really have any specific medications. So again, the other thing to keep in mind is that there are many other causes for dysphagia. So if we do find that maybe the muscles are a little bit weak, but we might find that the person has an esophageal stricture where there's not enough room for the food to get through. The doctors can go in and open that up. They can dilate that. Sometimes the food is difficult to pass through the top of the esophagus, and doctors will go in and actually kind of cut that muscle to open it up. So if you think about it sort of being a funnel, if we can make that funnel a little bit wider up at the top, going into the esophagus, then sometimes that can help. So there are some procedures that the GI doctors can do short of a feeding tube that can also help. So I think the other thing that is important is, again, patients being their own advocate in their care. And I think particularly the patients that are involved with the Myositis Association do a very good job of that. But oftentimes that means sometimes pushing your doctor a little bit to get the dysphagia evaluated. And really the best starting place for that is with a speech therapist and with a modified barium swallow. If that doesn't identify the problem, then the next step would be to go to a gastroenterologist to have them look down and see if there's a structural cause for the swallowing problems. But I do think a large percentage of doctors don't really understand swallowing very well. They're not that comfortable in terms of how it should be evaluated, and so it is important to use the speech therapists to really be able to evaluate the swallow and then to figure out if there's ways to improve upon their swallowing mechanisms.